You know the conduction system in the heart. There is SA node, and from there are three AV nodal tracts connecting to the AV node, and another bundle called bundle of Bachmann goes to the left atrium, and from the AV node bundle of His arises, and that bundle again divides into right bundle branch, left bundle branch. Left bundle branch again divides into anterior fascicle and posterior fascicle, which further divides into Purkinje fibers. And what is the blood supply of AV node? AV node is supplied by AV nodal artery, but from where AV nodal artery arises? In 90% of subjects it arises from right coronary artery, but in 10% of population it can arise from left circumflex artery. So AV node and proximal portion of the bundle of His is supplied by right coronary artery. And you know the right bundle branch, left bundle branch, left anterior fascicle, left posterior fascicles, these are supplied by left anterior descending artery, and left posterior fascicle also has collateral supply from posterior descending artery, because left posterior fascicle is located in the posterior part of the left ventricle, so it also receives collateral supply from posterior descending artery. So this is about blood supply. So blood supply of the proximal portions of the AV node and bundle of His, proximal portion of bundle of His, and distal portion like bundle branches, fascicles is different. There is a cutoff, you have to remember that, because if there is occlusion of right coronary artery, you can get conduction problem in the AV node. But if the problem is if there is plaque rupture in the left anterior descending artery, you might see features of complete heart block. You might see features of left bundle branch block, because those are supplying the bundle branches, fascicles. Second thing you need to remember is the nerve supply, parasympathetic supply. AV node is supplied by parasympathetic fibers, but the bundle branches, fascicles, these do not have parasympathetic supply. Only the SA node, AV node has parasympathetic supply. So if the problem is in the bundle branches, in the fascicles, those are damaged. Let's say there is LAD occlusion and bundle branches are dead. Then if you give atropine, will it work? No, because even if you block the parasympathetic fiber supply to the AV node, the problem is not in the AV node, the problem is in the distal part, in the bundle branches. But let's say if there is right coronary artery occlusion and AV node is infarcted, then if you block the parasympathetic supply to the AV node, then heart rate can increase, because AV node is supplied by parasympathetic fibers, not the distal portions of the bundles, branches and fascicles. So this is one of the clinical implication. So how do you identify whether the problem is in the AV node or problem is in the lower portion? Lower portion, I mean in the bundle branches, in the fascicles. So you can see QRS width. If the QRS is more than 3 small box, it suggests problem in the lower part, in the bundle branch fascicles, because if the problem is in the distal part, there is QRS becomes widened, because there is conduction from ventricular myocytes to myocytes. So there is delay in conduction, that's why QRS gets prolonged more than 120 millisecond. But if the problem is in the AV node, then you can see QRS is normal within 3 small box, right? So this is one of the clue that you can differentiate whether the problem is in the proximal part or distal part. Another is that if the problem is in the AV node, then you will see there is progressive prolongation of PR interval and followed by sudden drop in QRS. But if the problem is in the distal part, then you can see there is constant PR interval and there is sudden drop in the QRS. There is sudden drop in 2 QRS, 3 QRS, 1 QRS. It will vary, but PR interval will be constant, like it, even it can be normal, but there is sudden drop in the QRS complexes. That is, we call Mobitz type 2 block. So if you see Mobitz type 2 block, it means the problem is lower down, not in the proximal portion of the AV node, not in the proximal part of the bundle of His, it is in the lower down. Infra-hisian we call it. Infra-hisian means there is bundle of His, and below that in the bundle branches fascicles, if the problem is there either due to degeneration, infarction, then there is progressive, constant PR interval and followed by sudden drop in QRS complexes. So have you thought why there is progressive prolongation in, if the problem is in the AV node but there is constant PR interval if the problem is in the lower down bundle of His, in the bundle branches? So why the PR gets progressively prolonged and there is sudden drop? So this is simple. This is the property of AV node. AV node is a gatekeeper. It does not allow all impulses from the atria to come to the ventricles, because if atria is beating at 200 and if the gate is always open, then it allow all beats to go to the ventricles, and ventricles will beat rapidly and it will not get enough diastolic time to fill the blood and patient might collapse. So that's why nature has designed a gatekeeper between the atria and ventricles, because atrial arrhythmia is common. Even if you take some stimulant medications, even if you drink tea coffee, there can be ectopic atrial beats. Right? And if there is no gate between the atria and ventricles, then all those impulses will go to the ventricle, and if all those rapid impulses go to the ventricles, patient might collapse. That's why there is a need of gate between atria and ventricles. So I was talking why there is progressive prolongation of PR interval. So when one impulse comes to the AV node, then AV node lets it go and into the ventricle, and then QRS impulse comes. Then again another impulse comes to the AV node, but AV node is damaged. It is degenerated or infarcted due to any pathology. Then it does not open its gate because there is problem in the AV node. So there is a delay in the opening of gate. Another impulse comes, then is again further delay. Then another impulse comes, this time this gate does not open and there is missing of beat. So ventricles say that, oh, I am not getting impulses. So again it tells SA node to beat. There is a feedback. So again P waves let the AV node let the P wave pass to the ventricles. So again QRS comes. Again there is problem in the AV node. So again the gate, this time gate opens slowly. So PR interval gets prolonged. Then another beat comes. Then again this time further gate becomes, the opening of gate becomes delayed. So there is again prolongation, right? Again another bit comes, this time it does not allow the impulse to go. It does not open the gate. That's why there is a progressive prolongation. If there is a pathology, if there is a degeneration of the AV node. But if the problem is in the bundle branches, then there is a fixed PR interval and there is sudden drop in the QRS complexes. So which is more dangerous? from clinical point of view, which requires pacemaker among Mobitz type 1 and Mobitz type 2? Definitely Mobitz type 2, right? Because Mobitz type 2 can go into complete heart block, because the problem is in the lower down the bundle of his, in the bundle branches, in the fascicles. That's why pacemaker, if you see a patient with Mobitz type 2 block, you have to ask symptoms. If he is experiencing syncope, you have to consider pacemaker. I will continue this video another time.